Good morning, good afternoon, good evening, wherever you are. Thank you so much for coming onto the call, and also thank you to all the viewers that watch this video on replay. For those of you that are here live, I want to welcome you, and you have an opportunity today to talk to me directly. Post your questions in the chat pad or talk to me live directly here. I am posting my link here in the chat pad, so you can click on that link and talk to me directly. Now, today, ask me anything: life support in ICU, ICU decisions, tracheostomy, and anything related to intensive care at home. That is what I'm here to do today, to talk about today. What makes me qualified to host a session or a show like this? Basically, emergency questions for families in intensive care and intensive care at home. My name is Patrick Hutzel. I am a critical care nurse with over 25 years critical care nursing experience in 3 different countries, where I've worked as a nurse manager for over 5 years in ICU, and I've been consulting and advocating for families in intensive care here at intensivecarehotline.com since 2013. And I can very confidently say that we have helped many families in intensive care to save their loved ones' lives. And that is by no means an exaggeration. You can look up our testimonials at intensivecarehotline.com, or you can look up our intensivecarehotline.com podcast section, where we have done client interviews. And whether it's the testimonials or whether it's the podcast, you can see and hear for yourself what our clients say, that I'm not exaggerating here, that we have helped many families in intensive care to save their loved ones' lives. Now, I'm also the founder and managing director of intensivecareathome.com. With Intensive Care at Home, we are sending our critical care nurses into the home for predominantly long-term ventilated adults and children with tracheostomies. And we are, providing intensive care at home services. We employ hundreds of years of critical care and ICU nursing experience combined in the community. There's no other service provider that can match what we are offering in the community. We are highly specialized, looking after long-term ventilation and tracheostomy in the community, also BiPAP, CPAP ventilation without tracheostomy, tracheostomy care without ventilation, by home TPN, home IV potassium, home IV fluids, home IV antibiotics, central line, peak line, Hickman's line, as well as port management, cough assist management at home. Anything really that's related to intensive care nursing that can be managed at home, we are managing at home to get patients out of intensive care, adults and children, free up an ICU, but improve quality of life for patients and their families, and cut the cost of an intensive care bed by around 50%. That's a pretty compelling argument. Quality of life, cut the cost, and free up an intensive care bed to look at a solution like intensive care at home. But most of all, it is for our families that use the service, so they can have time in the comfort of their own home rather than in a busy, noisy, and often not so patient and family-friendly ICU. So we're also providing level 2 and level 3 NDI support coordination with intensive care at home, and also TAC work, TAC case management. Okay, without further ado, let's again welcome our viewers. Also, if you like my videos, like, comment, subscribe. I do these YouTube lives once a week around the same time. I usually go for about an hour. So now is your opportunity to ask questions. Type your questions in the chat pad, or simply click on the StreamYard link and talk to me directly here. Don't be shy. I don't bite. I'm here to answer your questions and your questions only. So let's look at questions that have come in during the week. I do want to talk about the Grace Scara case that was in the news in the last few weeks. Grace Scara, a 19-year-old girl that died in October 2021, I believe 2021 or 2022. And her dad, Scott Scara, has got a blog where he's blogging about Grace. Scott has also been a guest on my podcast in the aftermath of his daughter dying. I just want to read out an email from Scott that he published as part of his email newsletter. So the trial has just finished a few weeks ago. The trial happened in Wisconsin in the United States, and the jury and the court decided in favor of the hospital. But let me give you some context by reading out an email from Scott that he sent this week to his email newsletter subscribers, which I'm a part of. So Scott says in his email newsletter, I started working on a summary of the trial this weekend. It is much more extensive than I expected and will be finished this week. I'm no longer under a gag order, which adds to what I have to document for the record. In short, I'm shocked by the verdict, but not surprised for many reasons that will be fully explained in the comprehensive summary I'm working on. Based on the jurors' immediate questions after receiving the case, the jury deliberated for only 15 minutes in a case that lasted 1 day short of 3 full weeks. Our team presented a better case, better witnesses, better experts, and had the truth on our side. The defense, through their experts, said, by being in a hospital, you are giving implied consent, and that the drugs that euthanized Grace were normal in an ICU, so no informed consent is necessary. Doctors informing the family is not even necessary for the 2 prior overdoses. The 3rd overdose killed Grace. Finally, their experts stated that a DNI stands for do not intubate. Intubation means the insertion of a breathing tube into the mouth, into the lungs, connecting them to a ventilator. So finally, the experts stated that a DNI is equal to a DNR. DNR stands for do not resuscitate. And a doctor can unilaterally place a DNR on a patient without consent, without a witness, without a signature, and without a DNR bracelet. No informed consent. The jury decided in favor of the defense. Only 1 juror stood against the verdict. In Wisconsin, there must be 10 of 12 jurors on either side. It was all over quickly and swiftly. This decision should scare anyone with ears to hear and eyes to see. Informed consent for medications is dead, and a doctor can unilaterally put a DNR on a patient without consent. Grace ended up having lorazepam, Precedex, morphine, and midazolam whilst on BiPAP. Was it euthanasia? There's also a video with an interview of Scott Scara and his wife and Grace's sister on YouTube. So the question that I want to ask here today is, was Grace Scara euthanized in ICU? Shocking verdict ends in informed consent in hospitals. Now, here's what I will say about this. What I will say about this is, From our advocacy work, after having worked with hundreds and hundreds of patients and families in intensive care, really all around the world, but predominantly in the United States, Australia, and the UK, that most of the time you can challenge whatever's happening at the bedside. However, the problem in Scott's case, or in Grace's case was they didn't quite know what was happening, and I've read all the case notes, and not the case notes, but I read, Scott's blog for quite some time, and it sounded to me like, he was sent away. One thing that stood out to me is that Scott did not have access to the medical records in real time, which is something we're always recommending here at intensivecarehotline.com. We are always recommending that you need to get access to the medical records day one, right? If you don't have access to the medical records, and if you don't get a second opinion in real time, which we can provide to you in real time as long as we have access to the medical records, you are flying blind, okay? You don't want to fly blind if you have a loved one critically ill in intensive care, right? But what I will say is that, let's just say Scott would have had access to medical records in real time, and let's just say he would have had us, look over it. We could have very quickly point out to him what was happening in real time, right? And it is important that you find out what's happening in real time. Now, case in point, many families in intensive care come to us, with the following situation. They say to us, oh, my mum, my dad, my child, my spouse, my brother, my sister, whatever, has been in ICU a year ago. We were told my family member won't survive. So it would be, quote unquote, in their best interest to stop life support and stop treating them, right? And we believed that. And we thought, oh, the doctors know what they're doing, and they must know what they're doing. So we agreed to withdrawal of treatment, and our family member died. Now, 12 months later, probably after many sleepless nights, they realized they've made a big mistake, right? And then they come to us and they say, oh, then they do their research online, and then they find my blog posts, they find my videos, whatever the case may be. And then they say, oh, I wonder whether there would have been another option. Hell yes. Hell yes. There would have been another option. If you look at the research and the statistics, 70 to 90% of patients in intensive care survive, right? Depending on what statistics you believe, right? So the odds are in your loved one's favor. So for you to agree to a withdrawal of treatment because that's the only option, and that's, quote unquote, in your loved one's best interest, is a whole lot of crap. It's a whole lot of nonsense. Do patients die in ICU? Absolutely, they do. But the first question that you need to ask is it a real or a perceived end-of-life situation? What's the difference? I'm glad you've asked. A real end-of-life situation is a situation in intensive care where no treatment, no medication, no surgery, no fancy life-saving equipment, no nothing will save your loved one's life. They're going to die. That's a real end-of-life situation. A perceived end-of-life situation, on the other hand, is there's a perception that your loved one might die, right? That your loved one might die while they're in intensive care. That's a perception. Now, to bring this back to Grace's situation, if you're giving a patient on BiPAP, lorazepam, Precedex, morphine, and midazolam, most of those drugs have respiratory depression as a side effect. Okay. And with respiratory depression as a side effect of all of those drugs, given that Grace wasn't intubated, chances that she would die were very high, and that is exactly what's happened, right? I call this euthanasia, and euthanasia is illegal. If you're giving medications such as lorazepam, Precedex, morphine, and midazolam while someone is on BiPAP, that is hastening death. And that is the exact definition of euthanasia. It's the hastening of death. And let me repeat, euthanasia is illegal. So for the courts to decide that it was legal for the hospital to give those medications to Grace, thinking that it would help her, thinking that she would survive, is devious, right? And I think anyone that has got significant ICU experience would agree with that. Leave your comments. If you have ICU nursing medical experience, leave your comments, right? To sign off on a unilateral DNR, right, is also illegal. You know, we've done a lot of research here at intensivecarehotline.com. We've looked at all the states in the US, or pretty much at all states in English-speaking countries and jurisdictions. In most jurisdictions, it is illegal to issue a DNR without patient or family consent, right? So I have not done any more research beside what Scott Scara has, published on his blog, but I can tell you the research that we have done is that, especially in the United States, a unilateral DNR is illegal most of the time. And as a matter of fact, we have been involved in reversing so many illegal DNRs just with our advocacy. Again, there's testimonies on our blog, right? I don't understand why this happened in the first place. But what I do see as a bottleneck here is that Scott Scara did not have access to medical records, because if he would have had access to medical records and he would have had a second opinion in real time, we could have told him what was happening, and we could have guided him step by step, right? But it's interesting that Scott also said as part of his podcast that he trusted the hospital system. Had never had to deal with the hospital system, and he trusted the hospital system blindly, right? So, but interesting enough, I've also done some research again about Wisconsin and the issuing of a DNR. And as a matter of fact, my research is showing that in Wisconsin, it is not legal to issue a do not resuscitate order in ICU or anywhere else without appropriate consent and following strict legal requirements. So I really do believe that Scott Scara here also has a case to challenge the verdict. Let me read out the legal requirements as far as my research is concerned. Wisconsin paragraph 154.17.29. Someone greater than 18 with a terminal condition likely to suffer harm or pain from resuscitation or CPR wouldn't restore function. So that wasn't the case. Grace Scara was a perfectly functioning teenager. Next, request and consent the DNR must be requested by the patient, their legal guardian, or a lawfully designated healthcare agent. And that person must provide informed consent after being counseled by the physician. None of that happened in Grace's case. Written and signed order. A written order must be signed by both the consenting individual and the attending healthcare professional. None of that was happening in Grace's case. Bracelet and documentation. Proper documentation in the medical chart and placement of a DNR bracelet or order form for it is required. Who can consent? Capable adult patient if they have decision-making capacity, legal guardian or healthcare agent if the patient lacks capacity. Family members without legal designation cannot consent. No consent, no DNR. If none of the above consenting parties validly authorize the DNR, or if the physician issues it unilaterally, the order is invalid. Federal policies additionally require that during an inpatient admission, life-sustaining treatments must be discussed with the patient or surrogate Writing a DNR without this is also a violation. Now, like I said, I have not looked at the court case, at the verdict in much detail. I haven't read it, but this is what my research shows. And this is also what my research shows in many other jurisdictions. But also, we have many families reaching out to us and asking, can we reverse a DNR? We says, yes, absolutely, you can. And here is how we do it. And we've done it many times. So what else is context here? There have been high-profile cases, such as the SCARA case, where patients or families claim ICU DNR orders were placed without consent. In another instance, a Wisconsin hospital faced legal action and licensing board review related to issuing a DNR without clear consent, highlighting the seriousness of these violations. So what are the implications for ICUs in Wisconsin? You cannot lawfully implement a DNR in ICU without proper consent. If the patient is incapacitated, the DNR requires valid legal authority, guardian or agent. Family members cannot fill that role informally. The process must include physician counseling, written and signed consent, physician's written order, documentation, and bracelet placement. The bottom line is that in Wisconsin ICU settings, issuing a DNR without valid patient or legally authorized surrogate consent, written order, and documentation is illegal and can expose providers and institutions to legal liability. If this scenario is occurring or has occurred, it may constitute a medical legal violation. Families or patients who encounter such actions should consider discussing concerns with the hospital's patient advocate, risk legal department, or consulting a healthcare attorney. Let me know, what you think. What do you think? Right? This is my research, and this is as part of the work that we are doing at intensivecare.com. We have researched pretty much every state in the US, every jurisdiction in Australia, the UK. Right? There's always a way to challenge it. I really do believe that, as heartbreaking that this sounds to the SCARA family here, I do believe that the missing link here right from the start was that they didn't have access to the medical records and trusted the hospital system blindly. Right? Also, this was during probably the worst healthcare crisis the world has seen in the last 100 years. Because, Grace was in ICU during COVID. And, one could argue that during COVID, or any rule was broken, right? ICUs were even under higher pressure than previously. Now, the other thing that I will say here is that Grace was also, she had Down syndrome, and maybe that was part of the decision-making from the ICU because she had a disability, but she was living a great life. I think Scott Scarra, anyone that has followed his blog, has made it very clear to everyone that Grace was a fully functioning 19-year-old girl, with a great quality of life. But I can tell you a wake-up call that happened for me when I still worked in ICU years ago. Would be over 10 years ago now, but I give you an example. I was working a night shift in ICU. And I remember like it was yesterday that, I was looking after a patient and my neighbor next door was looking after another patient. And I remember the nurse next door that was working with me was a junior nurse. He had only started in ICU. He was very green. And I remember I was very busy, whatever was happening with my patient, don't know the ins and outs, but patient came back to my neighbor. Patient came back after surgery with necrotic bowels, and they opened up his abdomen, and, he had a peritonitis and abdominal sepsis, and, he was on high levels of life support. He was on inotropes, he was ventilated. Things weren't looking good. I remember that this gentleman would have been in his early to mid-50s, and he was living in a nursing home with Down syndrome. Because things weren't looking grim, were looking very grim, it was decided that night by the ICU team that, oh, this person won't have any quality of life because he's got Down syndrome anyway, and we should just, stop life support, and we should just let him die. Pretty much the family of the patient was informed over the phone that this is what, the ICU team thinks that should happen. Now, cutting a very long story short here, the patient was dead the next morning at the end of my night shift. All I do remember was, because I was busy, I didn't have time to spend with this junior nurse and guide him. Wasn't my role in that night, on that night shift. All I said to him, I remember, is, do you think that this is right or ethical or moral, what's happening here? And I remember he shrugged his shoulders. He was new in ICU, didn't really know the lay of the land. He was still learning the clinical things that needed to be learned. Now, my gut was screaming that this is wrong, what was happening there, even though I didn't have the time to, find the exact details out. But what I can tell you is, this is a real thing, and that was way before COVID. That was another wake-up call for me to realize, hang on, what's happening in ICU is no longer ethical or moral or right to patients or families. Why are we doing what we're doing? We have to dig deeper in terms of our values, in ICU. So, to bring it all back to, was Grace Scarra euthanized in ICU? Shocking verdict, ends informed consent in hospital. So, number one, I strongly believe that Scott Scarra here has a very strong case to challenge the verdict. Whether he'll do that or not, of course, I don't know. I wouldn't also know whether he's got the option to appeal the verdict. I don't know. So, it's what Scott wrote on his blog post this week or in his email newsletter is very disturbing and should alarm anyone with a loved one in ICU or in a hospital. Because Scott Scarra's daughter, Grace, died in a hospital ICU after being given a combination of lorazepam, Precedex, morphine, and midazolam while on BiPAP. If you know anything about those drugs and the impact they have on respiratory drive, this is not standard. This drug combination, especially in a vulnerable patient on BiPAP, suppresses breathing to the point of death. So yes, the question must be asked, was this euthanasia? Scott and his legal team took this case to trial in Wisconsin in the US. The trial lasted almost 3 weeks. The jury deliberated for only 15 minutes before ruling in favor of the defense, i.e. the hospital. Let that sink in 15 minutes after 3 weeks of evidence, expert testimony and arguments. Scott's team had stronger witnesses, better experts, and most importantly, the truth on their side, but in the end it didn't matter. Here's why this verdict is absolutely terrifying. The defense claimed implied consent by simply being in a hospital. They argued no informed consent is necessary for the medications given, even those that led to Grace's death. They stated that a DNI, a do not intubate, order equals a DNR, do not resuscitate order, which is absolutely incorrect and medically unethical. Worst of all, their experts claimed that a doctor can place a DNR unilaterally without consent, without a witness, without a signature, and without informing the family. No bracelet, no notification, nothing. That is a chilling precedent. If this verdict stands, then informed consent in hospitals is dead and will end. Families are no longer part of the decision-making process, and doctors can make life-ending decisions without your knowledge or approval. This is exactly what we warn families about every day at Intensive Care Hotline. And we've done it since 2013. Once your loved one is in ICU, you must assume control. You must question everything. You must never blindly trust the system. As I always say, the ICU has its own agenda. It's up to you to protect your family member. Grace was given a cocktail of drugs known to suppress respiration. She was already vulnerable. There was no informed consent. Her father was removed from the room, then she died. If that doesn't sound like euthanasia, then what does? We stand and have always stood with the Skara family and encourage everyone to watch Scott's breakdown of the verdict in a video interview. This case should shock the conscience of every family ICU advocate or ICU family advocate. We must not let this become the norm. Informed consent must be protected. Family input must be respected, and unilateral DNR decisions by hospitals must never be allowed. And if you're in a similar situation, you mustn't wait. Reach out to us at intensivecarehotline.com, where we advocate for families 24/7 in intensive care. I argue that if Scott had reached out to us in real time, we would have put a stop to the ICU euthanizing his daughter. And like I said, it is no exaggeration when I say we have saved many lives for families in intensive care. And that's documented on our testimonial section. It's documented on our intensivecarehotline.com podcast section, where we've done client interviews. But I also think it's important today, whilst we are talking about Grace Skara's case, that we look at the difference between DNI and DNR. I do believe that's also important that we look at this today. I also think that families in intensive care know the difference, and that families in intensive care get familiar with the terminology, right? Because terminology matters, right? Terminology matters when you are having a loved one critically ill in intensive care. If you don't know the terminology, the ICU team might be throwing words or terms around where you have no idea what they're talking about, right? So what's the difference between DNI and DNR? So a DNI stands for do not intubate. Intubation means the insertion of a breathing tube into the mouth to start someone on mechanical ventilation, right? So, and this is also a question we get all the time from families in intensive care. You might hear the doctors or nurses say, your loved one is DNR or DNI, and you're left wondering what that even means. So let's break it down. But before I break it down, I also, just honing in from what I mentioned a minute ago. A DNR or a DNI cannot be decided unilaterally. So, DNR stands for do not resuscitate. What does that mean? It means that if your loved one's heart stops or they stop breathing, CPR, also known as cardiopulmonary resuscitation, will not be performed. No chest compressions, no defibrillation, no advanced cardiac life support. In short, they're letting your loved one die without attempting to revive them. DNI stands for do not intubate. That means that if your loved one has trouble breathing, they will not be put on a ventilator or a breathing machine, through a breathing tube or an endotracheal tube or a tracheostomy. They might still get non-invasive ventilation support like oxygen or BiPAP, CPAP, but they will not be intubated and mechanically ventilated. Now, here's the real kicker. DNR and DNI are often lumped together in ICU, but they're not the same thing. Your loved one can be DNR, but not DNI, meaning they don't want CPR if the heart stops, but they do want ventilation if they're struggling to breathe. Next, DNI, but not DNR, meaning they don't want to be ventilated, but do want CPR, although this scenario doesn't make much clinical sense. it's still sometimes documented that way. DNR and DNI, which means no CPR, no ventilation. So here is why all of this matters. We've seen over and over again in ICU that DNR and DNI are sometimes misused or miscommunicated, and that families are left in the dark while decisions are made behind their backs. We've even seen DNRs and DNIs placed without consent or proper explanation, and that's simply wrong and it's illegal. So if your loved one has been labeled DNR or DNI, you need to ask, who made that decision? When was it made? Was the family or the patient involved in that decision? What does it mean in terms of treatment and care moving forward? Here at intensivecarehotline.com, we believe that unless it is a clear, informed decision made by the patient or by their medical power of attorney, it should not be enforced blindly by ICU teams. What have I been saying here for many years? The biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. It's exactly what you're dealing with here. If you are in a situation where the ICU team is pushing a DNR or DNI, or if your loved one has one in place and you don't agree with it, never given consent, and you know that your loved one has not given consent, you need to reach out to us here at intensivecarehotline.com. We can help you advocate, challenge those orders, reverse them, and keep your loved one alive if that's what you and your families want. You know, unless you speak what I refer to the secret intensive care language, you will find it hard managing this territory. I want to give you another scenario that we've been dealing with in the last few weeks, and I will make selective videos about this, but I do want to talk about it here as well. A couple of weeks ago, actually, as a matter of fact, 2 weeks ago from today, actually, I had a phone call from a gentleman saying, look, his brother is in ICU. He's had a hemorrhagic stroke, which means he's had a brain bleed, and he ended up in ICU unconscious. He had surgery to put an EVD into the brain, an extraventricular drain, to drain some CSF, which is brain fluid, as well as drain the bleed. They couldn't remove his skull, which is sometimes what happens after brain bleeds, to manage the ICPs, the intracranial pressures, which is also known as the brain pressures, right? He had a significant midline shift, which means the brain is shifting from left to right or right to left. Then he didn't wake up, right? And he had high ICPs. And with high ICPs, he, got in a deep coma. They sedated him with propofol, midazolam, and fentanyl, and also cisatracurium. And they were also giving a hypertonic saline, right, which also helps with high brain pressures, right? So after about a couple of weeks, he still wasn't waking up. And whenever the ICU team was trying to remove sedation and the cisatracurium, his brain pressures kept going up, and they had to re-sedate him, right? So with all of that said, the ICU team was pretty much telling the family from day one that, he's very sick and he won't survive. And they were even, telling the family, oh, today is the day, meaning today's the day where he's going to die, with no clear indication what that would look like or why he would die, right? So it was all a bit bizarre. They reached out to me and, I said to them, look, here's what we need to do to turn this situation around. At no point in time was a tracheostomy offered. The family made a complaint to the ICU and to the hospital. and with a good result. You know, I also help them to advocate, of course, you know, and like I said, with much success. You know, now we're at a point where all of a sudden the ICU says, you know, we're even considering a tracheostomy to buy him time, right? To buy him time to improve. Now, nobody knows if this gentleman will improve or not, right? Nobody knows. But one thing is for sure, if you give in and you let your loved one die, you know the outcome. If you don't give in and you advocate for your loved one and you want to give your loved one every chance, you don't know the outcome, but you know they've got a fighting chance. You know, and also what they then, as time went on, what the hospital also suggested was, oh, tomorrow we'll extubate him, and if he can't breathe, which I was assuring the family he won't, with a Glasgow coma scale of 3 to 6, or that they will just give him morphine to help him die. Now the family was absolutely outraged by that suggestion, and I'm outraged by that suggestion, right? This man is a young man, right? And you know, I think I was outraged, the family was outraged, but you know, we've got a plan forward here. The patient is still alive, the ICU has backed off. Now that they know the family has someone on their side who understands intensive care inside out. You know, also there have been delays in getting access to the medical records. Why is that? What is it that the ICU is worried the family would see in medical records? Right? So they want the family to give consent to end-of-life care, to letting their loved one die, but they don't want them to see the medical records. Can you see the hypocrisy of that? Right? It's very hypocritical, extremely hypocritical. Right? So the good news is, you know, we have come a long way here from, you know, the ICU wanting to end this man's life by extubating him and by giving him morphine, to now, you know, we are discussing the potential of a tracheostomy. Now, also for our clients, you know, and this is a case in Australia actually, and also in Australia, for example, now with the NDIS, right? A stroke is an NDIS funded diagnosis, i.e., you know, this gentleman would get help through the NDIS in the community, right? With or without a tracheostomy, it doesn't matter. So what ICUs don't know in Australia in particular is they don't know that NDIS is here to stay and that NDIS will fund situations like that, right? So keep that in mind. But the bottom line is, families in intensive care don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And I can't stress enough that if you don't have an advocate by your side, you will fight an uphill battle. Unless you're an industry insider, you will fight an uphill battle. You know, it's as simple as that. So having an advocate by your side will make all the difference, you know. So now, if you're watching this in real time, type your questions into the chat pad or click on the StreamYard link that I posted in the chat pad, and you can talk to me directly. Now, also want to read out a question from an intensive care at home viewer that I had actually yesterday. Just give me 1 second. I just need to find the email. Yes, so here's the email. Hi, Patrick. My son is 2 years of age. He's ventilated 24/7 and with a tracheostomy. I'm just wanting to know, do you have support workers or are your staff nurses? We only have funding for support workers. So this is actually a client in Australia. Also, we already have a few support workers. If we move over, I just need to know how much you pay the workers, as I don't want them to have a pay cut, and can we move them over? Are your support workers fully trained so I can leave my son alone with them? And do I get the interview and pick them, as I feel my son needs certain support workers? We are in a fight at the moment with NDIS to get 24/7 funding during the weekend, but we have 22 hours Monday to Tuesday and 19 hours Wednesday, Thursday, Friday, and weekends. Saturday, 19 hours, and Sunday and public holiday, 16 hours. Do you have clinical nurses in Sydney that helps train the staff? From Amanda. So, Amanda, thank you for your email. If I understand you correctly, your 2-year-old son is ventilated with a tracheostomy. Now, for children that are ventilated with a tracheostomy, 24/7 critical care trained nurses are required. This is based on evidence and documented on our website at intensivecarehome.com. We have the mechanical home ventilation guidelines there, which are evidence-based. So that means exclusively critical care trained nurses with 2 years minimum critical care nursing experience can safely look after ventilated and tracheostomy adults and children. That's evidence-based, coming out of over 25 years intensive care at home nursing in Germany, and it's coming out of over 12 years intensive care at home nursing in Australia with intensive care at home. So this is actually evidence-based. So let me continue in answering your question. If the NDIS is not currently funding 24/7 nursing care with critical care trained nurses, it often means that the advocacy and reports provided to the NDIS planners have not included the correct information and evidence from relevant clinicians and allied health professionals. All of our adult and pediatric NDIS clients who are ventilated with a tracheostomy have 24/7 NDIS nursing care funded with critical care trained nurses. We have unfortunately seen many adults and children with ventilation and tracheostomies die in the community in recent years when looked after by support workers. No amount of training can prepare support workers for the inevitable pitfalls and medical emergencies that can occur. We do have clients and critical care trained nurses in Sydney, and we have the expertise to advocate for and obtain 24/7 critical care nursing funding from the NDIS, otherwise we wouldn't be in business. We do not train support workers because as APRA registered nurses, we are not permitted to do so. As an APRA registered nurse myself or any of our highly skilled nurses would risk losing our registration by doing so, as it goes against our APRA guidelines. Whilst I understand that some registered nurses from other NDIS providers are training support workers on ventilation and tracheostomy, I don't believe they fully understand that they, number one, are risking their APRA registration, and number two, they don't know how to advocate and use their APRA registration to secure 24/7 critical care nursing funding for ventilated adults and children with tracheostomies. The good news is that we can help you succeed in obtaining 24/7 NDIS funded nursing care for your son. We also have pediatric ICU nurses on our team, that can guide you through this. And I'm very, very confident that we can help you with this, because otherwise we would not be in business. So I hope that helps you understand what's happening with support workers versus ICU nurses in the community, and that you've simply been getting the wrong advice. You also need a new NDIS support coordinator by the looks of things, or at least you need an NDIS support coordinator. That knows what they're doing. Most NDIS support coordinators do not know what they're doing. That's at least in our niche. I shouldn't generalize, but when it comes to ventilation and tracheostomy, they often don't know what they're doing because, with all respect, they might have worked at the bank last week. They might have worked at Coles or Woolworths last week. Who knows, right? So unless you know what you're doing, your NDI support coordinators do not understand what needs to happen when it comes to the advocacy for your son. But, I feel 100% confident that we can help you here. So reach out to us here at intensivecaretHome.com. Okay, so other questions that have come in during the week that are relevant for our audience here is, so, what's an email? ICU keeps pushing hospice for my mom on a ventilator and tracheostomy, but she wants to leave. So I had an email from a subscriber that says, doctors in ICU keep pushing hospice care for my mom on ventilator and tracheostomy, even with improvement. She has end-stage kidney failure and needs dialysis. I need help. She wants to leave. So, let me ask you this. Is your loved one in ICU with a tracheostomy and on a ventilator? Has the ICU team told you there's nothing more we can do, or she has no quality of life, or you should consider hospice care? Even worse, are they saying that even though she's improving? Well, you're not alone. We get calls every day from families in your situation who are being pressed into end-of-life decisions, not because it's what's best for the patient, but because it's what's best for the hospital. Let me repeat that. Many ICUs push hospice not because the patient is dying, but because they want that ICU bed back. Now, let me tell you what's really going on. Your mom has end-stage kidney failure. She's on a ventilator, has had a tracheostomy, and now she needs dialysis. And despite all of that, she's improving. And most importantly, she wants to leave. Yet the ICU team is trying to override her will to leave with a recommendation for hospice. That's completely unacceptable. Now, here's what they don't tell you. Having a tracheostomy and being ventilator dependent with dialysis needs does not mean the end by any means. It means she needs time to be stabilized, time to adjust, and most likely time to wean off the ventilator. Or if she can't be weaned, time to transition to long-term care at home with a tracheostomy, a ventilator, and dialysis support. Yes, you heard me right. It can be done at home. I just talked about intensive care at home a minute ago. It is absolutely possible to have your mom to live at home with a ventilator, tracheostomy, and dialysis with a service like intensive care at home. We've helped families in exactly your situation bring their loved ones home safely with 24/7 ICU level care. Don't let the ICU sell you on a death sentence when life is possible. And you can find more information, of course, at intensivecaretHome.com. Here's the truth. Hospice. No ventilator, no dialysis, and no active treatment. It means they're withdrawing treatment. It's end-of-life care. Your loved one will die. So, if your mom is alert, fighting, stable, or improving and wants to live, then hospice is not appropriate. You need advocacy. You need information. You need power. You need control. You need influence. You need peace of mind. And you need to make sure your loved one gets best care and treatment always. Don't let ICU make decisions for you or for your mom, especially if she doesn't want them. Take control, take action. We're here to help at intensivecarehotline.com. So, I'm going to wrap this up in a minute. If you have any final questions, type them into the chat pad. If you need help in intensive care with a family member, go to intensivecarehotline.com, call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com with your questions. Or if you need home care for intensive care at home, please reach out to us as well. And we can help you with critical care nurses at home With intensive care at home, we are currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We're sending our critical care nurses into the home. And we're also providing level 2 and level 3 NDIS support coordination, right? And we are employing hundreds of years of critical care nursing experience combined, right? No other service provider in Australia brings a higher skill level or brings more intellectual property into the community than intensive care at home does, right? And if you know someone that brings a higher skill level into the community than we do, then please let me know. I want to know about it so that I know we need to improve, right? So just want to clear that one up. We also have a membership for families of critically ill patients in intensive care, and you can become a member if you go to intensivecarehotline.com, if you click on the membership link, or if you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. In the membership, you also have exclusive access to me and my team, and we answer all questions intensive care related there. In the membership, you also have exclusive access to 21 ebooks and 21 videos that I have personally written and recorded. And all of that will help you to make informed decisions, have peace of mind, control, power, and influence, making sure your loved one gets best care and treatment always. So, any other questions or comments? Now, if you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home. Click the like button, click the notification bell, and comment below what you want to see next, what questions and insights you have. And, I keep doing those weekly YouTube lives every Sunday morning, 10:30 a.m. Sydney, Melbourne time, which is currently 8:30 p.m. on a Saturday night Eastern Standard Time in the US, which is 5:30 p.m. Pacific time in the US. Now, I wish all of you a wonderful Sunday or a wonderful weekend, a great week, and stay happy, stay healthy. I wish you and your families all the very best. Take care for now.